Was that why in that also that picture also we saw some of the attendants in some special clothing?
Yes, that's why I said those are the things. Do we have those things in places now? Have the hospitals been supplied such gowns? Because if you have such a patient, health workers probably run away from such patients. So if you have as an isolation room
for fear of contracting.
Yes, so you should have those gowns in places, and basic things. The first thing is even washing of our hands. Once you touch any patient, you should wash your hand. But often in our hospitals, we don't even have water.
What about the gloves?
Well, you will wear gloves definitely, but I'm talking after each procedure with each patient, you should wash your hands. Simple things like even soap. I've seen where they put a whole bar of soap in a plastic at the water side, and then everybody is using that soap. That's even another means of getting things across. So it should be gel soap, or you cut the soap into pieces where resources are limited. You cut it into pieces. So when you just take your own small piece, you wash and then you discard it.
These are some of the things people really don't know. You just reminded us of what the Minister for Health did say about awareness, sensitization, but it would seem that, well, we haven't actually done enough in that regard. Yes, quite frankly, you said, well, you're not into, well, politics or administration of governance, but from what you have seen so far, unless you read the papers, you watch television, you listen to radio, would you say we have done well in awareness for the people?
Well, as regards awareness, I think we are doing well. But in terms of putting the necessary action in place, the sample we received from Nasarawa was through courier means, and it was by an established protocol. So once they got the sample, they sent it to Professor Milabu on a Friday evening, and Saturday and Sunday was in the lab throughout.
So dengue fever and Ebola has some kind of similarities in symptoms.
Yes. There is a group called viral hemorrhagic fever. Hemorrhagic being that it can cause bleeding. So basically, they would all present with fever, and when somebody presents with fever in this part of the world, the first thing you think is malaria or typhoid fever. But it's very acute. And then when you start getting history, like about 3 or 4 people have similar symptoms in the same house, and they are all acutely ill. They are all very ill, vomiting, stooling, it's fever, and then maybe there's some elements of bleeding. Then that's a viral hemorrhagic fever. So dengue virus, Lassa fever virus, Marburg virus, Ebola virus, Congo Crimean virus, Rift Valley virus. So there are a number of viruses under these viral hemorrhagic fevers. So the protocol is actually against viral hemorrhagic fevers, every fever that is very contagious, that often gives bleeding. So that's, once you see such a, presentation, at that point, it's only a very good established laboratory that can say it is Ebola or this. Mm-hmm. But once you see that it's a viral hemorrhagic fever, then you want to be very, very aware of the right thing to do.
Can we also talk about the probability? Do we also do things like, what is the probability of it spreading to our country, for instance? Are those things that we can calculate?
No, because the borders are porous. We are talking about Liberia, Sierra Leone, Ghana, Nigeria. Everybody travels. I know people go to buy cars.
So Ghana. You would say the probability is high?
Yeah.
Would you say it's high, or it's low, or are we at risk? What can we gauge our risk and where we stand?
Why we can't gauge our risk? Because people migrate. As we speak now, Saudi Arabia won't allow people from Liberia and Guinea to travel for Hajj. So if Saudi Arabia then so far away is taking such a step, so that means it can just once people are moving, you never know what anybody's abhorring.
So as a people, we too ought to be vigilant, and
yes,
you would not advise, for instance, if I'm at home and you notice that maybe your member of a family has fever all of a sudden and it's acute, what would you advise? Because oftentimes what we tend to do is self-medicate, try this first before we say, okay, let's go to the hospital if it hasn't worked. In this particular circumstance, or under the circumstances, what would you say we should do?
Well, the thing about this kind of infections is that the acutely ill person is not likely to travel. It's probably the person that has had contact and then has not had symptoms that probably, would engage in travel. But the real thing is that we should have a good, health-seeking behavior. We are still working now on our national health bill. Everybody because you pay some amount of money, the hospital is not often the first place
of choice.
Yeah, so it's a general thing. It's just not about a particular infection.
Because part of what you mentioned as the key aspect of preventing this from spreading is the information. Because if they don't know what the symptoms are, everybody could just carry on as to one of those malaria, and lo and behold, if it's Ebola, then that's a very serious matter.
Yes.
So the awareness here.
The awareness. Then I should say that things like, I mentioned hand washing, isolation room.
Which we take for granted.
Which we take for granted. Isolation room in the hospitals. Proper disposal of, anything used on these patients. You'd have to incinerate them. You try and go for most reusable items. And then again, even burying of the dead. When such persons die, then there should be some established protocol in getting them buried, just not the typical things. And then even in that hospital, you do need to provide security. The nurses often will tell patients that, you can't see this person, the way we all throw tantrums that I would like to see my relative. So you need security also for such kind of wards so that people will just not be visiting. You need adequately trained staff to manage such a room, not just everybody, visiting such a patient.
So apart from having those rooms, we should actually go around and check and make sure that they are up to the required standards.
Yes, all the basic things. You may not have like a world-class center, but you would have all these small needed materials.
You should have the basics.
We have stethoscope that we call UNESCO. It's quite cheap. So you're going to put one there. Thermometer, you're going to put one there. All the what do you call it, medicines the person will be using are right in that room. So you don't go to take another thing from any other room again.
And put there.
Right there. And then the kind of staff that should attend to them would not be somebody that's done 96 hours call. I remember once I did 96 hours call straight, and I was about going home on a Monday evening after 96 hours. And just the last patient, I had a pinprick because I was fatigued. And, it was an HIV positive patient, and I had a pinprick from the patient. So definitely you'd have to change the rotation of such persons. Persons working there are not the ones that would stay 24 hours. It should be brief, and then you do your own bit and you move on.
Okay. Now, how would you also look at post-discharging the patient? For instance, if someone has Ebola virus, the person has been isolated, possibly successfully treated, which rarely happens, but assuming the person is able to scale through, how would you say that the person should still be held for a while? Or do you think that there could be stigma attached to that person? Do you also see those kind of trends coming in?
Unfortunately, we don't have so. For instance, we've not had anybody in Nigeria, or if we've had maybe the person died. And so in the countries where they had a number of people surviving, I was reading an article and they said the virus was isolated from the semen of a man 60 days after infection. But the good part is that it's always in the early part that the person is infectious. So if the person has been treated or supported, because we don't have drugs for it, so you really just support the person. And then the person survives. Really.
What's the period for the that can be described as early days? If this one is 60 days, how many days can be early?
Well, incubation is 2 to 21 days. That's for getting the infection. So if somebody has contacted anybody with Ebola virus, then over the next 21 days, one should watch the person comes down with symptoms.
After 21 days, the risk reduces, or potency, or what?
If the person doesn't come down with symptoms, then it's not likely the person contacted the virus.
Do we have people, sorry Mark, but do we have people who have some kind of immunity against the virus?
It's a difficult question to answer because the fatality has been high. People have died. So you don't really know. You need people to survive. before
And
you
there's no
start.
vaccine
There's no vaccine yet.
yet. I like that. That's some kind of hope.
Yeah.
So meaning there's work in progress towards having a vaccine for it.
Yeah.
But answering that question in terms of how long the person has to stay away, I mean, after being supported, what would you advise?
I won't be in a position to advise.
I know, but
because I have never managed a patient
Just so
like
we
that.
don't have
But-
cases of stigma.
But I know that hospital stay has been up to 3-4 weeks in such persons, and after which they are normally discharged to their relatives. And since there weren't reports that a patient was brought back with relatives, that means that the person didn't thereafter infect the relatives. Because most of these things are based on case reports. You discharge a patient you treated for Ebola, and the person is back 5 weeks with relatives with the same symptoms.
Wow.
Then I'm just giving
An
it
instance.
didn't happen. That's somebody will definitely report that. For instance, this Ebola we are talking about, Medicine Without Borders (MSF) were actually in Guinea carrying out a malaria project, and then they discovered that people were coming in very ill, vomiting and all that, and then they called the experts from Hamburg and from France, and they came in. They took away about 20 samples, and they reported.
That's blood samples, right?
Yeah, blood samples and body fluids. That was about mid-March, and by April 16, a publication is already out that it's a strain of the Nigerian Ebola virus. So when if anybody survives now and then they discharge, there will be follow-up, and let's say we get a report that after that discharge, after 6 months, the same person comes back with it to the family, then that means that we'll probably be thinking of.
Is there a chance that someone can get it twice?
Ah.
I mean, if you ever survive it the first time, is there a chance that you can survive it again or get it another time?
I don't know.
Really? Okay.
So frequent washing of hands can actually help.
Yes.
And you shouldn't use one big soap.
Yes, we should have flakes. We should
More
have
dangerous.
gel. We should have water. Health workers. My wife does not allow me to hug my children or hug her when I come back from work. I'm supposed to go and change first before I come to visit the children. And even you would see a lot of nurses that they hardly wear their uniform home. They leave it at the workplaces. So there are a lot of things that HIV and hepatitis actually, brought this to the actually change our the revolution of managing patients with infectious diseases. But when you are talking viral hemorrhagic fever, then you need to go the extra mile.
All right, thank you, Dr. Bamidele Oke, who is a research fellow of infectious diseases at the Nigerian Institute of Medical Research. Is also a clinician. Thank you for coming on this morning.
All right.
All right, we'll return after this break. Join us again.